So I make no apology for going through quickly. You can read faster than I can talk. Those are my learning outcomes. This is what I'm going to cover. But we are in that interdisciplinary space. And the British Society for Lifestyle Medicine only started in 2016. We're 8 years old. It has grown exponentially from 100 attendees to 200 to 400 in the Cardiff. Obviously, that little pandemic thing had an effect on us too, not least. Yeah, it doesn't bear thinking about it. But we've had to change how we do everything. But we are still growing. We have over 3,000 members. It's very multidisciplinary. Over half of those are GPs. But, you know, do come, do join. We think that this is a main driver for equipping the world to cope with this epidemic of lifestyle-related disease and for us to live more healthy. And let me explain over the next 5 to 7 minutes why that is. Because we are growing, and it was only really last year. There's been long-term, about 20 years, an American Lifestyle Medicine Global Association. But only last year, the World Lifestyle Medicine Organization was incorporated as an independent charity in Switzerland, and the European Lifestyle Medicine Council is growing. So we have networks, and those networks are growing like we are. I've spoken at Croatian and the Portuguese, and spoken in Greece. You know, they are on a similar path to us. So it's a movement, okay? Now, sadly, obviously, we lost Michael Mosley a few weeks ago in Greece. Greece is intensely hot, and he was going to speak at our meeting. But, you know, that work goes on. His wife has made it very clear to go on, and there are lots of people who are doing a lot of high-profile stuff in this space. So let's tell you about our approach to lifestyle medicine. There are 3 principles, 6 pillars, and we do group consultations, and that's about creating a community concept, recreating community that we have lost in most of the Western world, but a lot of cultures have kept. It's not just about having structures and grants and, you know, smart homes. It's about people coming together and using the latest technologies to do it. So firstly, we need to recognize social determinants on health. And obviously, Michael Marmot's updated report and the amazing 14 years we've had from what seems to be, apparently from what Rishi says, a very successful government. Let's see whether they stay in power. We need to have people able to eat. We need basic schooling. We need to have that. But after that, we have proven techniques that can support people to make positive changes to the lifestyle, which have less effect, probably 20% at most, compared to the 30% from social determinants. But these are important together. And then the 6 pillars, and these are based on the 6 modifiable risk factors for non-communicable disease from World Health Organization. So these are evidence-based and underpinned, and we know we can change them. It's healthy eating, mainly plant-based, not least for sustainability, but also for its health effects. Physical activity, recommended guidelines, 150 minutes of moderate. You know, strengthening exercise. Michael Mosley was very keen on his planks and his kind of high-intensity exercise because it was very effective. Harmful substances. We shouldn't be smoking. We shouldn't be drinking too much. You know, there are cultural issues here we need to address. Toxins is a huge thing. Sleep, very important for quality and duration of life. Mental well-being as a positive thing, not just avoiding mental illness, and healthy relationships to bring it all together. So we believe that when you incorporate those changes and that ideal way we want to live through group consultations, we can leverage existing healthcare systems, existing clinicians to deliver more care at a better quality to more people. So who did that first? Let's go back in time. In 1905, and I'd like to acknowledge Beth Brates, who's just stepping down as the president of the American College of Lifestyle Medicine. She first found this slide. He started with groups, and he used this approach for people who were poor, who had TB, who couldn't afford to go into hospital, couldn't afford to stop working, and through what he called class method, they met regularly, and their outcomes were just as good, if not better, than the people who were admitted to hospital at that time. Okay, so with a small amount of money, charitable funding, he set up a system that worked. It rolled out for chronic disease, and then he was also the forerunner of group psychotherapy when he moved to the Boston dispensary. So what we're looking at is a very successful and sustained model of care that we forgot about, because these publications in 1907 in JAMA, these are quite good journals. Journal of the American Medical Association, conference reported in the New England Journal of Medicine, that's their local rag. when you work in Massachusetts. But these weren't available until they were scanned, and they're still not easily indexed, these kind of older publications. So this is over 100 years ago, and it was very successful. This is our kind of STEAMA, our Centre for Integrated Research into Musculoskeletal Aging. We did some artwork and some poetry to try and engage people in what we were doing. And this is a kind of Dali-esque version of Joseph Pratt. He has broccoli for hair. He has broken cigarettes for eyebrows. He's got sleep in one eye, social connectedness in the other, training shoes in his moustache. And his cravat represents the British Society for Lifestyle Medicine logo. Of course, all these little ants in his pocket are people in the group consultations. So, this is the problem. Our waiting lists get ever worse, and of course, there's even a junior doctor strike this week. And this is replicated across Europe, across the world. We don't have enough clinicians to deliver care. So, and obviously, massive excessive deaths. The UK did particularly badly as regards Europe and the global situation because we were late, we were slow, we were ineffective. But what great care looks like is it meets this quintuple aim of healthcare. Great outcomes. If you've got diabetes, you reach your target. If you've got blood pressure, high blood pressure, you reach your target. But also, you have patient satisfaction, and maybe the clinician should be happy as well. They shouldn't be so stressed that they go off with work stress, okay? Because that impacts on care. And then it needs to be cost effective. In fact, obviously, Don Berwick, who came up with the triple aim, he said low cost. I don't think it needs to be low cost, it just needs to be cost effective. And then you have to embed effective education. That's not just the education for the patients, it's education for people coming through the system. So that means we should be embedding this stuff in undergraduate systems. We're going to have a session on that led by Jane Dacre at our meeting this year. But actually, postgraduate education, where you change people's approach to care by seeing this in practice and then being inspired to deliver it yourself. So it ends up multiplying the effect. It's like these kind of pyramid schemes, except it's good. It's good sharing instead of bad sharing. If each of us teaches this to 10 people, in 5 years, the whole world could be practicing this way. So, lots of different models, and this slightly holds us back. Some of the models are really good for access, like cluster visits, drop-in groups, group medical appointments. Some are good for chronic care. And Ed Nossinger did lots of stuff on shared medical appointments, various versions. One of the most powerful ones was a publication on multimorbidity by a group called STOPS on the cooperative healthcare clinic model, and group medical visits done through the IKSAD British system. But then in that sweet spot, you've got models good for access and chronic care. That's Joseph Pratt's class method, our own group clinics in arthritis, and group antenatal care. But there's lots of evidence this is very effective in all regards. But we need to not get bogged down in the name of it. Group consultations is the overarching term. We need to persuade PubMed to mesh on that term so it's easily accessible. But at the moment, systematic reviews need to do searches in all these terms. Looking forward, obviously, we've learned during the pandemic you can deliver this kind of care virtually, and the engagement events that we run now for menopause with the Homerton, they might have 400-600 people online. Most of the people attend one session, they've got all the education they need. People who have greater needs want to go on HRT can attend smaller groups with maybe only 15 or 20, and it's much more interactive at their level, but they're on the platform already. So the virtual group system works well. If you have an in-person group and we have a limited size of room, I have to say my biggest groups had 32 people attending. So they might be struggling to get in here. So then we were already experimenting before the pandemic with hybrid, where you put up an iPad and a Bluetooth speaker, and you actually have the option of either coming. The thing that really annoys me is when my patients say, I wanted to come to clinic, but I was too ill. My joints were too sore, my ambulance transport didn't come, my daughter-in-law didn't come to give me a lift. You should still get your care. You shouldn't let anything get in the way. So we need to be flexible in how we deliver care, and having virtual, in-person and hybrid solutions along the pathway is the best way to do that. But the group care delivers the efficiency, it delivers the peer support. And I'll show you what the patients say. Lots and lots of evidence across life. I'm not going to dwell on this, but we've got transformative examples. So Kids Bowel and Bladder Service, they put this in. They saw 37 families the third time they did it. So they had 100 people in the room. Their waiting list, their 3-month waiting list was wiped out the first time they did it for 17 families. Okay, so it means better access, better care. And with things like stigmatizing conditions like bowel and bladder problems, amazing for the kids to know they're not alone, the parents to know that other people are affected, and you're sharing and you're supported, and the problems start to improve straight away. Diabetes, hypertension, obviously these are important because they're common. Groups are more effective, very simple. They're at least as effective, but more cost effective in the worst studies, and they're more effective in some studies. The very biggest study was in China, in community, over 1,000 people in an RCT of a group intervention at the same size of group that we run, about 20 per group, for blood pressure, better blood pressure control. Well, that has measurable effects on future outcomes, predictable. And then I mentioned the Scott study on multimorbidity, because lots of people think you can only do it if you've got one single condition, but that's not true. Everything went in the same direction, better direction, when you did it for multimorbidity. And there are systematic reviews, as you'd expect, supporting this. This is a recent one you can look up in my reference list. Here's an example I like to share. David Unwin, the low-carb GP, he runs groups, monthly groups for his low-carb diet, published his 8-year data last year. 50% of his diabetics, pre-diabetics come into the group, 50% remission in the people who do, with a predictor, if you see them early, higher remission rate, 77% seen early. But even when people had 15 years disease, it's still 20% remission rate. Lower weight, off the drugs for diabetes, off the drugs for hypertension, lowest prescribing costs in the country. So this is win-win, amazing outcomes without any expensive injections. So that's what we should all be doing. And this is our positioning for this. It's a value proposition for healthy aging, which needs to be embedded, yes, for pandemic recovery, but there's such high value here. We're looking at basically improving people's self-care, improving people's connectedness with or without technology. That means they spend much less time here, and here, and everybody's happier and healthier. Because we shouldn't be medicalizing the world. Everybody should be able to live their lives. This is the journal that we run, and this was the first special issue we did. If you want to scan the QR code, feel free. Compassionate Communities is all about changing everything, bringing ourselves together. And there's various, powerful articles in this. I'd flag you to Julian Abel and Tommy Wood's editorial, but every single issue in that article in that issue is well worth reading. That's the content. Social genomics, you heard it here first. So overall, this is happening, and a new government's going to be much keen on this. This QR code will take you to the Personalised Care Institute blog that's just published, which links into a lot of this evidence. Women's health I've mentioned. There's going to be a menopause toolkit going live shortly for the NHS. We are engaged with NHS England. We have one pilot site in Cheshire and Merseyside. Hopefully a new government will roll that out across the NHS. Very engaged with future outpatients, and hopefully we'll become embedded in the Further Faster programme as well. And this is what the patients say. They say they're more listened to, better access, better understanding, better decision making, more involved, would recommend to family and friends. On the left is the website, the group consultations. On the right is the app, which allows you to download free resources once you register. So I'm just seeing people scanning in the room. Obviously online you can take screenshots, show them to your family. Once everybody's finished their scanning, I'll wind up, because this is my final slide really. Come and visit us. Our meeting is the 19th till the 21st in September at the amazing Glass House in Newcastle. Just living opposite there at the moment. Amazing, inspiring conference. You'll be more than welcome. And this is what I've covered, and these are my references. Very happy to take questions in the discussion. Is that 15 minutes?
Yeah.